Hello, and it's a pleasure to be here today. I'm Dr. R. Scott Wright, a professor of medicine, associate editor of Mayo Clinic Proceedings, and a cardiologist at Mayo Clinic in Rochester, Minnesota. Today, I'm joined by one of my early teachers in internal medicine and a distinguished professor of gastroenterology, Dr. Michael Camilleri. Dr. Camilleri has been a gifted and world-class researcher in bowel motility issues for a number of decades at Mayo Clinic, and really has been a pioneer in this field globally. He has taught many of us over the last 2 or 3 decades at Mayo Clinic. And Michael, I'm not willing to admit how long ago it was that I came to train, and probably in your first year or two on staff at Mayo. Your reputation is incredible. Your skills and achievements have been exemplary. And just as an aside, Michael has mentored so many young professionals over his career, including our current CEO, Dr. Ferrugia, that we wanted to interview him for this series to capture the essence of what he's done and let him share his excitement about what he's doing and what he continues to do at Mayo Clinic. So Dr. Camilleri, welcome to the series.
Thank you so much, and thanks for that very generous introduction.
You're quite welcome. Tell us about your early years at Mayo, where you came to Mayo from and your background prior to Mayo, and what it was like in your first 4 or 5 years in Rochester.
Well, thanks. I went to medical school and graduated from the University of Malta Medical School, and I was very fortunate to receive a British Commonwealth scholarship that allowed me to do my postgraduate training in general medicine and gastroenterology at the University of London in England. I was a trainee there for just about 6 years at the Hammersmith Hospital. And I finished all my training, did my an academic degree in physiology. And then I was kind of too young to be let loose. So my mentors in England said, why don't you do what many of us have done? And it was called the BTA, which stands for Been to America. So it turns out that one of my mentors, Vint Chadwick, had been a research fellow at Mayo Clinic in the 1970s, in the early 1970s. And so, unbeknownst to me, he had actually written to his former mentors here at Mayo Clinic. And all I know is that I received a letter that says, would you like to come and join us for another research fellowship? And so that's what we did. My wife, and at the time we had one son, we came to Rochester in 1983, and we had a wonderful time. It really opened my mind to patient-based research. What I really was enamored with at Mayo was one of the things that my mentor, Juan Malagelada, originally from Barcelona in Spain, what he said to me is that one of the great things about Mayo Clinic is that what you do in the laboratory in the morning, you can apply to your clinical practice in the afternoon. And keep that in mind, because that will make you very happy throughout your career. So I've continued to listen to that guidance I received in the mid 1980s, and I often am stimulated to study things in the lab following questions that arise in the clinical practice, and vice versa. We developed methodology in the lab that we were then able to validate and bring into the clinical practice for the last 3 decades. And we might have time to talk about some more specifics about that. But you asked, what were the first 4 or 5 years at Mayo? They were great fun. I had to go back to Europe for a couple of years because I had come on a J1 visa. And then I was very fortunate that the leadership of the Division of Gastroenterology and the Department of Medicine offered me a position to come back on staff in 1987. And so that's essentially how my story started at Mayo Clinic.
Wow, that's a great story. Who were some of the physicians in the late 1980s that you maybe did research with or who were instrumental in the Division of Gastroenterology at recruiting you back?
That's great. So it's almost like the who's who of gastroenterology. Sidney Phillips was the head of the GI research unit. He had a major interest in intestinal and colonic physiology, especially secretion and motility. And actually, he had done a lot of the basic work that led to our understanding of the importance of evacuation of the bowel and the way in which the pelvic floor muscles work. He also worked closely with people like John Pemberton and Roger Dozois, Eric's dad, and Keith Kelly. All of them were colorectal and abdominal surgeons. And this was a great confluence of people who were interested in physiology and surgical pathophysiology and pharmacology. And it was a great place for me to learn the confluence of those three disciplines as they related to gastrointestinal diseases. There were also other legends and heroes at the time, people like Nick LaRusso, who was in the Department of Medicine eventually as chair, but at the time he was also helping us move to understand mechanisms. So not just studying the physiology, but understanding why, what is the reason? So that question kept coming up in our minds, so that as we applied our clinical research, we tried our best to introduce novel methodology, whether it's cell biology, biochemistry, immunology, molecular biology, genetics, to try to understand the mechanisms of disease. And it was this wonderful confluence of surgeons, gastroenterologists, hepatologists, which is what Nick was and still is, and even people with major interest in biochemistry and cell biology, like Larry Miller. And one of my colleagues in the lab at the time was Greg Gores, who of course is now our executive dean of research. So it was a great milieu, a great environment to enhance one's thinking processes and grow with the opportunity to study mechanisms, not just descriptive aspects of the research.
And I think that has to be one of the pivotal changes that you and your generation of investigators brought at Mayo, because I came in 1989 and we worked together in the summer, I believe, of 1990. And it was really an exciting time to be working with you as an internal medicine resident, because you were quite inspirational. I don't know if I've ever shared this with you, but you really inspired a number of us to think about careers as clinical investigators and research scientists, about really trying to fundamentally answer questions about why and how. Why are the diseases and how are the processes contributing to those diseases coming out that we saw in the hospital or in the clinic? But it sounds like Larry Miller and Nick LaRusso were really instrumental in helping you sort of mature into a well-funded and a comprehensive, having a comprehensive program at that point. Would that be fair to say? Or
that's absolutely right. And of course, I remember, Scott, when we were doing rounds at St. Mary's together on the inpatient services. But again, I'll remind myself of things that I used to hear in the GI research unit as a young staff member. It doesn't matter what. The important questions are why and how. And that was inculcated in everything that we were trying to do. Whenever we presented a new research protocol, we had to address the question, why and how is that happening? And I think that was really a very important lesson I learned in my early days here at Mayo.
And I seem to recall that even then, in those early days, you had a number of fellows and post fellows coming from other institutions to work with you. I think Charlene Phillips is a name that I recall from those days, and probably more than I can remember. But you had developed quite a lab even by the mid-90s. Isn't that so, in terms of what you were doing?
Yes, we were very fortunate. Of course, a number of the fellows were also participating either in the NIH-funded T32 program, which other people much more senior than myself were instrumental in making possible here at Mayo. But also many of the fellows participating in the GI and Hepatology Fellowship, who have a statutory 1 year of research, chose to do that research with us in the GI research unit. And I was a beneficiary of all their hard work, and hopefully in turn, I gave them things to think about and helped them to develop their own careers. And the nice thing about Mayo at the time as well was, I mustn't forget this, one of the most important interactions and research activities was with colleagues in the endocrinology division. So Bob Rizza in particular, and subsequently also Adrian Vella, who was one of his fellows, were instrumental in helping me go back to something I learned when I was a postgraduate student at the Hammersmith Hospital in England, in London. And I met an endocrinologist who, of course, is world famous, called Stephen Bloom. And he said to me, don't forget, the largest endocrine organ is actually the gastrointestinal tract. And so I really found a wonderful way to interact with our endocrinology colleagues, because even then we started to examine the incretins, in other words, GLP-1, GLP-2, peptide YY, glucagon. And lo and behold, 20, 25 years later, much of the pharmacology that we talk about nowadays with regard to obesity and metabolic syndrome management really comes down to many of those early observations, particularly that Bob Rizza was stimulating, and the thinking and the hypotheses that he had us work on to test. And the wonderful thing was that we were looking at nutrient emptying from the stomach and the metabolic and the endocrine effects, the incretin responses that were very critical to understand how those incretin hormones work and how glucagon works. But it so happens that this becomes very relevant as we go fast forward into what's happening nowadays with the treatment of obesity and metabolic syndrome.
Well, Mike, you have tackled a challenging field in GI. I remember when we worked together, you were beginning to look at motility issues, and especially patients who had a very challenging diagnosis with irritable bowel. And you also had a real interest in sort of nutrition and weight regulation. And today in 2023 and beyond, when individuals watch this, they're going to look back and say, well, that was so obvious, GLP-1 inhibitors help people lose weight, and, satiety control and blah, blah, blah. But this is all a field you've discovered since you came to Rochester, you and several other people, obviously globally, but you've brought so much insight into this with collaborations with Adrian Vella and Bob Rizza that we now have pharmacologic targets that actually explain and can bring about physiologic change. So when was that aha moment for you? Was it in the 90s or in the early 2000s when you started to see all of this physiology and mechanistic work come together, and you knew that you were on to something that would ultimately lead to a lot of discoveries and a lot of explanations for why people had a lot of symptoms? When I came to Rochester in the late 80s, I met a retired Mayo GI doc named Jim Kane. And Jim told me one of his workings at Mayo was to see all of the difficult patients in the 70s who had issues with motility and other things that no one could explain. And Jim had a wonderful bedside manner and probably was part-time psychiatrist, really, and part-time GI specialist. But now your generation has led the discovery to explain the science behind all of this. And was there a time that you had the aha moment, or did it just come sort of piecemeal by piecemeal, and you look back and now it's obvious, but at the time it was a journey with really not a map to follow? You sort of created your own map and roadmap to do.
That's a really insightful question, Scott. I'm going to try and separate out the thinking process behind the incretins and the obesity side of things, and think differently about, or separately rather than differently, about the kind of the irritable bowel or functional gastrointestinal diseases, or as they are now called, the disorders of gut-brain interaction. So let me try and sort of turn the clock back. So in the 1970s and 1980s, the tendency was to diagnose conditions that were caused by a dysfunction of the GI tract based on the symptoms of the patients. And so there were these symptom-based diagnostic criteria. And that was the prevailing way in which clinical gastroenterology for 40% of all patients with GI symptoms, that's how practice occurred. And it was really being immersed in the GI research unit and brushing shoulders with the giants, with the Sid Phillips, with the Juan Malagelada, and as we mentioned before, Larry Miller, Nick LaRusso, and my peers, Randy Pearson, Greg Gores, that we started thinking more about, can we identify biomarkers that could be actionable? Now, this didn't come overnight. We first started to realize that there might be mechanisms that we could identify, preferably with non-invasive tests, that would tell us whether a patient has fast or ultra-fast transit through the stomach or through the colon, or slow or ultra-slow transit of content through the stomach or through the colon. So that was the first step, and that really was the late 1970s and early 90s. And then there was the opportunity to also study novel medications that were being developed by the pharmaceutical industry to see if we perturbed or if we restored normal functions from those dysfunctional states, whether the patient's symptoms would get better. And so we were very fortunate to have the methodology that allowed us to actually prove that those biomarkers, those tests that we were developing related mostly to motility, but subsequently also to biochemical changes, whether restoring those to normal could improve the patient's symptoms. And to cut a rather long story short, we were actually very fortunate to be demonstrating the proof of concept that many medications that subsequently were approved by the Food and Drug Administration were first shown to be efficacious at studies done in a single center, which was Mayo Clinic. And these medications include let's say, cisapride, which is a prokinetic for gastroparesis, prucalopride, which was a prokinetic for the colon in constipation, linaclotide and lubiprostone, which are secretory agents, which we use for patients with chronic constipation. Allosetron, which was a medication for patients with diarrhea predominant irritable bowel syndrome. So to cut a long story short, by having well-validated measurements, physiological measurements that allowed us to identify mechanisms of the patient's symptoms, we not only were able to understand how to help to diagnose these patients' underlying pathophysiology, in other words, why are they having that symptom, but then we were also able to use the pharmacological approaches to identify what is the mechanism that we can correct. So in the case of the medications I mentioned, very often these were related to either too little or too much serotonin that was causing, in the case of too little, constipation, in the case of too much, diarrhea. In the case of constipation, sometimes you needed to push more water into the small intestine and the colon. And that really led to medications like linaclotide and lubiprostone, and subsequently others that we weren't involved in the proof of concept, but they were derivatives of the same mechanisms, like plecanatide, for example. So that was one very interesting phase. And I can tell you, this is not overnight. The ability to measure may have come over a short period of time, but the actual validation of the test and then the proof of concept was really about a decade's work. And I'm going to give you a story before I come to the incretins and the GLP-1s. So one time I remember being at a party in December, and it was rather boring. And I was on the hospital service, and we had a patient that we thought could be bleeding from a Meckel's diverticulum. And so we thought, okay, let's get a Meckel's scan. And when I was at this party, the conversation wasn't too interesting. My mind suddenly went to, wow, if I can give intravenous technetium and pick up the gastric mucosa in the Meckel's diverticulum, surely I can see the stomach if I can give intravenous technetium. So about 20 yards away, I found a colleague from nuclear medicine at the party, and I said, do you think this would work if we give intravenous technetium, that we'd be able to see the stomach? And the colleague actually did a lot of technetium systemebe scans where technetium is given to examine the heart. And he said, yes, the darn stomach gets in the way when we're trying to image the important organ, which is the heart. So anyway, to cut a long story short, we took that, wrote the protocol through the IRB, did the first study in humans, and that is what led to the non-invasive measurement of gastric volume and gastric accommodation. So the technetium is taken up by the gastric mucosa, and then we use a SPECT camera, which slices through the abdomen. And then one of the great advantages that we have at Mayo is that the basic scientists had developed imaging programs to assimilate or assemble all of the scans taken from the stomach. And we were able to use that technique in order to reconstruct the stomach and get its volume during fasting and postprandially. So whereas previously we'd have to put a 1 liter balloon into the stomach through the nose or through the mouth, we now had a non-invasive test, which could be done in first, we did it in 30 minutes. Now it's become a 20-minute test where the patient just receives an intravenous injection and drinks a can of Ensure, and we can non-invasively measure satiation, satiety, and the problems that patients get when they have indigestion or dyspepsia. So that was interesting, and we made it into a clinical test, and we validated it and all of that. But again, we applied that same method now in patients with obesity to ask the question, or in patients who are undernourished, to ask the question, does the degree to which the stomach accommodates or enlarges after a meal impact the ability to take food, to what is the calorie content that can be ingested depending upon the size of the stomach, if you wish. Now, we knew from the literature that patients with bulimia had very large stomachs, but most of our patients with obesity or overweight don't actually have bulimia nervosa. So again, we were able to use that information that we learned to then go across to understand the function of the stomach in patients who are overweight or obese. And that also led us to trying to learn, and we did this again with Adrian Vela and Bob Rizza, what's the effect of vagal function in patients with obesity or diabetes, which, as you know, can cause a vagal neuropathy. And also, what is the effect of medications such as GLP-1 agents or DPP-4 inhibitors, dipeptidyl peptidase 4 inhibitors, that increase endogenous GLP-1, but don't have the same deleterious effects on stomach emptying or the same accommodation effect that GLP-1 itself has. So again, this was crossing the bridge, putting a foot in both sides of the river, if you wish, going across from gastroenterology into endocrinology and into imaging, and enjoying the whole spectrum of investigation. So I hope that answers at least some of your questions.
It does, and I think it really highlights how you have approached and continue to approach your whole medical and scientific career. That is, as a person who has a mind of curiosity, disciplined by science, expecting mechanisms to follow scientific processes that are discoverable. One of the observations I've made has been that since 1990, and now of course that's 33, almost 34 years ago for both of us, and you have remained as curious and as passionate about research as you were when I met you in our younger days. What are your secrets for staying passionate and curious for those maybe who are watching this and need a little inspiration or need a little rejuvenation because they've once had it and now they're feeling depressed or burned out and they want to just recapture that? What are your secrets to success if you have any that you might share?
Well, I think that one of the most important things that keeps me invigorated is being immersed in the clinical practice and having the time to be able to ask questions like, why is that happening, or how does it happen? And so very often the questions that I'm trying to answer really originate from observations in patients. And, I can tell you that even this in the past month, we have generated questions that we are going to be pursuing from observations in the clinical practice. Sometimes they're relatively mundane questions, like how do we apply a diagnostic tests to be more effective? How can we utilize some of the information that we have from the wonderful databases that are available at Mayo, and that we have accumulated thanks to funding from the National Institutes of Health and several hundreds of patients that we've been able to study. But the ability to investigate and to interrogate all of that mechanistic information very often allows us to pose the next questions. So in summary, I get a lot of my original enthusiasm from questions that arise from encounters in the clinical practice. I can also say that being immersed at Mayo Clinic with a focus on the patient and the tradition within the Division of Gastroenterology to explore novel ways of not only diagnosing but also treating patients. This legacy that we have from those who preceded us is something that I feel is something that drives me forward as well. There was a wonderful investigator at Mayo Clinic in the 1970s, and he passed away a few years ago. His name was Alan Hoffman. And Alan Hoffman went to the University of California, San Diego before I came to Mayo. But I eventually stumbled upon the importance that he actually proved in the early 1970s with papers in the New England Journal and Journal of Clinical Investigation on the importance of bile acids in patients with diarrhea. And Alan used to think about me as one of his mentees because I continued the legacy that he started at Mayo. And he very often would introduce me, and he was a very wonderful and very generous person who would introduce me at national meetings and things as a surrogate mentee or one of those situations. But Alan and what he did was also very important for me because I have continued to develop diagnostic tests with our colleagues in lab medicine and pathology and in the immunochemistry core lab that really have impact on so many diverse illnesses, not only within the GI tract or within gastroenterology. So obviously, bile acids are absorbed in the terminal ileum, as we all know. And if you have an ileal resection or ileal inflammation from Crohn's disease or radiation, then you're going to have bile acid malabsorption. But our colleagues in oncology who deal with neuroendocrine tumors, our colleagues in I got a phone call the other day from colleagues who treat patients for stem cell transplants, and they're seeing this inflammatory response in the intestine causing this torrential diarrhea that's actually caused by bile acid malabsorption. So the tests that we developed in the research lab that became clinical tests through the Department of Lab Medicine and Pathology, now we can see the impact that ultimately the discoveries of Alan Hoffman in the early 1970s are coming to roost. They're coming to have a very significant impact in the clinical practice. And I'm I'm very proud to have been able to foster that development of those diagnostic tests. So those are some of the things that kind of keep driving me. It's the questions that arise in the clinical practice and trying to understand the mechanisms and then develop the right ways to diagnose and hopefully to treat.
Well, thank you. Thank you. For our GI trainees and fellows who are watching this, what would be your advice to them for their early careers? What are the things that they can do that you did that help them start strong, and any advice on what they should avoid?
Okay. I think one of the most important parts of my development was that I invested time to help myself to develop. So, you know, I did a research fellowship, which led to a master's degree and subsequently now a doctorate in science from Imperial College London. And I did didactic courses that really gave me the biochemistry and the cell biology and a little bit of molecular biology in the late 1970s that I could at least address some of the questions that were mechanistic. So that's the first point. You've got to have time to invest in yourself to develop the way to explore the investigation. At Mayo, we have wonderful opportunities in the Certificate of Clinical Research, biostatistics and epidemiology. Those are other courses that I followed here at Mayo with people like Joe Melton and Alan Zinsmeister. And these have really been very helpful from a methodology standpoint to continue the discipline of doing the research the right way. So first point, invest in yourself, spend some time, embrace the opportunities that come your way. And yes, you're going to have a 30, 35-year clinical career sooner or later. And yes, you're going to be scoping for the next 25 or 30 years. But you need to train your mind to be able to maximize the opportunities that are going to come your way. So that's the first thing. The second is, try to find the areas that are going to be of major interest to you, because this is something that you need to have as part of your daily life for the next 25 or 30 years. I mean, I often say I have a 12-hour-a-day hobby, and 6 hours every weekend writing. And we're fortunate that our commute to the clinic is only 1 or 2 minutes or a few minutes, and so we don't spend hours on the road trying to get to and from our place of work or our place of hobby. So that's the second thing. Invest the time necessary to find out what's going to be your major interest. And then, of course, try to find mentors, like I was very fortunate to find both in London and at Mayo Clinic, that are going to help you not only with the discipline to do the writing and to do the grant applications, but also to continue to pose difficult questions to you so that you can continue to grow. And then the one thing I think I regret in my career is that perhaps I took it too seriously, and that one needs to take time, especially when your kids are still young, to spend that precious time with them. I sometimes say to my younger colleagues, I do regret the time that I didn't spend with my children playing soccer and seeing them play soccer, because that time came and went really rapidly. So think about that as you think about work-life balance. Remember the importance of the sacrifices that your family, sometimes even your children, do to help to foster your hobby and your career. So those are some of the things that I've thought of over time.
Oh, thank you very much. What a pleasure today to have with us Dr. Michael Camilleri, professor of gastroenterology and molecular biology, and really a pioneer in understanding mechanisms of brain bowel dysfunction and motility. And he's shared with us some wonderful advice, not just for young faculty and fellows in training, but for all of us. Michael, thank you for sharing your time and your experiences with us. And and for sharing all of these perspectives. And most importantly, as your colleague, I want to thank you for your inspiration to all of us, to myself and to many, and for the collaboration you do on a daily basis. Mayo Clinic is great because of committed and great scientists and physicians like you. So thank you, Michael, for all you do. Thank you for joining us.
Thank you so much, Scott. It's been a pleasure doing this with you. Thank you all.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.